Hey study buddy, this is your local 4th year med student Eli Chen, and welcome to Pre-Rounds, where we'll talk through a case, review some high-yield topics for exams, and hopefully become a little less confused together. This is the Step 1 version of the case, where the information is geared towards that exam in particular. Check out the Step 2 version of this case if you're preparing for that instead. And lastly, I'm not a real doctor yet, so all the info and sources are taken from the real doctors and their guidelines listed in the description. And a disclosure, all of this information is for the purpose of education, and none of this should be taken as medical advice. So let's get started with our case. We have a 36-year-old man with 1 week of flank pain. Was he laughing too hard at a pun? Or maybe he went running and he got that weird side stitch that gets worse every time you breathe? I don't know. Let's find out. So a little bit more about his history. The pain started 1 week ago when he was trying to pee, and it's been on and off since then. Now it's gotten worse, and that's why he came in. He's been peeing more frequently, but still able to make it to the bathroom in time. Tylenol doesn't really help. The pain feels sharp and stabbing on his flank and back, and sometimes it goes down to his lower belly and groin. When it's on, it feels like an 8 out of 10, and sometimes it decreases to a 2 out of 10. He doesn't have any fever or chills. He has some nausea, but no vomiting. He has some blood in the urine, but no discharge, and he doesn't really feel burning with urination either. He has occasional diarrhea and abdominal cramping, but none recently. On review of systems, he doesn't have any weight loss or fever and chills. He has some nausea, and he also has blood in his urine. So let's translate some of these symptoms into medical terms. So the first thing is the blood and urine, which is called hematuria. Hematuria can be broken up into 2 big categories, one of them gross and the other one's microscopic. Gross hematuria is when pee looks like Hawaiian fruit punch in a toilet bowl. Like your nickname would be Doja Cat because you're painting the town red. Microscopic hematuria, on the other hand, just has a few red blood cells only found on urinalysis, so it doesn't look frankly red. When someone says they're peeing more frequently, we should try to find the underlying cause. It could be from overflow or urge incontinence, but he is able to make it to the bathroom on time, or it could be from obstruction and not emptying enough. Polyuria, on the other hand, is too much peeing in volume, which would then explain the frequency. But this requires over 2.5 liters of urine. So let's finish up the history. His past medical history is significant for Crohn's disease, which explains his occasional diarrhea and abdominal cramping. But he hasn't really had any of that recently. He hasn't had any surgeries. His social history is significant for his last sexual activity, which was with women 8 months ago, and he does use protection regularly. And the only medication he's on is infliximab for his Crohn's. The physical exam shows an alert and well-appearing man. His heart has regular rate and rhythm. His lungs are clear and equal bilaterally. His abdomen is soft and non-distended, non-tender, and he has normal bowel sounds and no CVA tenderness. He has a normal appearing scrotum and genitalia, no masses, and he's alert and oriented ×4. So let's talk a little bit about the diagnosis. The most likely diagnosis here is kidney stones. This explains his colicky flank pain and the blood in the urine that he gets sometimes. But we should also talk about close seconds when it comes to this diagnosis. I would say UTI is up there as well. This can also cause a blood and urine, but he doesn't really have burning with urination. And urethritis from a sexually transmitted infection is also in consideration. But I think it's unlikely because he doesn't have any discharge, and his, like your nickname would be Doja Cat because you're painting the town red. Most recent sexual activity was rather distant at 8 months ago. So let's break down kidney stones a little bit. So 80% of the kidney stones are made up of calcium, but they could be made up of a lot of different things too. And this is an aside, but I looked up the world's largest and heaviest kidney stone, and that was removed from a man from Sri Lanka in June of 2023. He was a 62-year-old retired soldier, and I'm gonna absolutely butcher this name, but his name was Connie. And this stone was 5.26 inches long and 4.15 inches wide. Larger than his actual kidney, which is only 4.6 inches. And it's also bigger than a standard coffee mug, which is about 3 to 4 inches tall and wide. Like the abdominal CT is absolutely insane. It just looks like a blob of bright calcification. It is frightening. This was removed with an open pyelolithotomy, of course, which is directly cutting and removing the stone from the renal pelvis. I could not imagine that stone passing 2nd grade, let alone through a urethra. And it's pointy on one edge. in too. Ooh. So onto the different types of kidney stones. The first one we'll talk about is calcium-oxalate stones. These crystals are envelope or dumbbell shaped and could be caused by a number of different things. One of them being ethylene glycol, like if you were chugging antifreeze. Another one's vitamin C, because excess vitamin C is broken down into oxalate, and that leads to the precipitation of oxalate in your urine. So if you were chugging those emergencies to cure a hangover, there is a such thing as too many packets. Another cause is low citrate in the urine, because citrate usually binds to the calcium. And lastly, malabsorption is a big cause. And for this patient, he has Crohn's, which has a special mechanism. Crohn's causes fatty acid malabsorption in the gut from damaged bowel. This causes the fatty acids to bind with calcium in the gut and lead to an increased reabsorption of oxalate. And then the oxalate gets deposited in the urine and precipitates with calcium there to form stones. There's also calcium phosphate stones, and these crystals are wedge-shaped. This is mostly caused by hyperparathyroidism, which increases the phosphate in the urine, and renal tubular acidosis, which makes urine too alkaline. There's also ammonium magnesium phosphate, or struvite stones. These crystals are coffin lid-shaped. They're caused by urease-positive bacteria like Proteus mirabilis most famously, but also Staph saprophyticus and Klebsiella. The urease turns urea into ammonia, which forms the staghorn calculi in the renal pelvis. Uric acid stones are rhomboid or rosette shaped. They're caused by high uric acid in the blood, usually from a breakdown of purines, which are your G and A nucleotides in DNA, and this could either be from gout or high cell turnover from treating leukemia with chemo. Additionally, dehydration can lead to urine concentration and uric acid precipitation. And lastly, there's cystine stones. These are hexagon shaped. I remember this because the cis in cystine kind of sounds like six, and hexagons have 6 sides. A hereditary condition causes cystine stones, and this condition impairs cystine reabsorption in the proximal convoluted tubule, and it also leads to decreased reabsorption in other amino acids such as ornithine, lysine, and arginine. This is the only one that you're going to see in kids. We'll also cover a little bit of the treatment. Calcium-based stones you can supplement with citrate, and also suggest low sodium diets. This is because sodium and calcium are reabsorbed in the proximal convoluted tubule. And if you have a low sodium diet, you're going to encourage more sodium reabsorption, and that also brings along calcium as well. And also lots of fluid for all of these kidney stones to avoid dehydration. For ammonium magnesium phosphate stones, you really got to treat the infection, like using fluoroquinolones for Proteus mirabilis, and possible physical removal of the stone if it's too big to pass. For uric acid stones, you can make urine more alkaline to dissolve the stones, and possibly use allopurinol if it's a continuous problem. Cystine, you can also make it more alkaline like uric acid stones, or you can use chelating agents like tiopronin. So to work up this case, he has a urinalysis that shows dark, yellow, but clear urine. His urine pH is 6.5, glucose is negative, there's trace protein, no bacteria, no leukocyte esterase, nitrate negative, 1 plus blood, and the specific gravity is 1.020, or 1020. Which is more concentrated than normal. To diagnose kidney stones, you'll need a non-contrast CT abdomen, and this allows you to best visualize the stone, measure the size, and check if there's any hydronephrosis. If the patient was pregnant, you can also use a renal ultrasound. You may or may not be able to see the stone, but you'll be able to check for hydronephrosis. So for this patient, you may see an enlarged kidney with edema and mild hydronephrosis. And let's say he also has a large, about 8 millimeter stone at the junction of the renal pelvis and the proximal ureter. So how do we treat it? To help it pass, we'll need to use some pain control. A lot of times NSAIDs are used for that. We can also help the stone pass. We can use alpha-1 blockers like tamsulosin. Alpha-1 receptors usually constrict the urethra at the bladder outlet, and blocking that allows the urethra to dilate and help that stone fall out. This is also used for benign prostatic hyperplasia, or BPH, where the prostate constricts the urethra. Usually this is used for distal and medium stones, around 5 to 10 millimeters, and if the stone is larger, you may need to consider surgical options. To avoid forming more stones, you'll need to advise the patient to hydrate and avoid dehydration, like controlling his Crohn's. And as for diet, we can limit sodium and oxalate intake. Oxalate can be found in leafy greens, almonds, potatoes, and rhubarb. We can also increase citrate with fruits and veggies. If the stones are recurrent, we can consider thiazide diuretics. The mechanism for thiazides inhibits the sodium chloride cotransporter in the distal convoluted tubule. And side effects with this medication can be recalled with the mnemonic hypergluc, GLUC. It stands for glucose, lipids, uric acid, and calcium. And in this case, we want calcium to be reabsorbed so that fewer calcium molecules are in the urine. We also want to make an outpatient urology appointment for this patient so that we have follow-up with an analysis of the stone material. And they're basically going to give him a strainer to catch the stones. And I thought this strainer was exclusive to urologists and that they needed to provide some kind of prescription for it. But apparently you can get a 2-pack on Amazon for $7.99. So our last section is curiosities and conundrums. And this episode's rabbit hole has a bit of a story. I saw a patient in the emergency department once, a young guy who's pretty fit, no medical problems, in a lot of pain. The lights were dim and he was curled up on the bed in a fetal position, or in medical terms, left lateral decubitus, and he had a kidney stone stuck in his ureter. It wasn't that big, so we sent him home with tamsulosin and NSAIDs for pain, but he asked why he had them, and the attending asked if he drank a lot of green tea, and he said he practically drank it every day. The attending said it could increase his risk for kidney stones, and I felt kind of bad for him because he said he thought it was supposed to be good for you. So I did some digging and thought I would spill the tea for you all. So there's been several studies about tea and kidney stones. For instance, in 2020, a prospective cohort study in the UK showed that for every additional 200 milliliters, about 7 ounces of fluid a day, the risk of kidney stones decreased by 13%. And this fluid actually included tea, coffee, and alcohol. And their idea was that these drinks actually have a diuretic effect, which decreases your risk. And on the other hand, a case control study in 2021 found that those who drank 4 or more glasses of tea a day had more than double the odds of having a calcium-oxalate kidney stone compared to those who drank less than 2 glasses. And here they considered the idea that tea had a lot of antioxidants that can prevent stone formation and that tea had encouraged more oxalate excretion. And now, hot off the press, a meta-analysis of prospective studies published in 2024 saw a dose-dependent relationship between tea drinking and kidney stones. They saw a drop in relative risk of kidney stones from 0.97 for 1 cup of tea a day to 0.89 for 8 cups a day, which to me seems like a lot of tea for little reward. They suggested the decrease in risk was due to the diuretic effect of caffeine and that some teas like black tea could increase urinary citrate levels. So it looks like tea might actually decrease kidney stone risk, but the most important part seems to be doing whatever you gotta do to pee more. So to recap some of our teaching points, we talked about the types of kidney stones, calcium oxalate, calcium phosphate, ammonium magnesium phosphate, uric acid, and cysteine. We talked about diagnostic testing with urinalysis and non-contrast CT. We talked about general management for small stones, pain management, and add alpha-1 blockers if needed. If it's large, surgical procedures would be done by urology. More of this is covered in the Step 2 version. And finally, we spilled the tea about tea. So that wraps up the case for now. Feel free to check out our other cases on the podcast in the meantime. Drop a comment to let us know how we're doing. And next time you pass a friend who's always a tad bit too stressed, gift them a cool little rock the size of a kidney stone that you passed for them, like a penguin courting a partner to build their nest. All right, see you in the next one.